Hello everyone and welcome. We'll get started in just a moment. We're just going to give everyone a chance to get in to the webinar. Okay, I think that we can probably get started. So hello and welcome. My name is Deanna Fournier, Executive Director of the Histiocytosis Association, and joined by Heather Fullerton, Director of Communications, and Kristen Nessison, Director of Community Outreach. We are beyond thrilled to have the opportunity to partner with the incredible team at the ECD Global Alliance and two of our incredible physicians for today's webinar. Before we dive in, I would like to run through a few housekeeping items with you. So reminders, this webinar is for informational purposes only. This is not a medical consultation, and we encourage you to speak with your medical team about your specific circumstances. Due to time constraints, we may not be able to answer all questions, although we will be taking questions throughout the webinar. We'll follow up with any additional information where possible. The webinar is being recorded, and so we'll send out a recording as soon as possible once the webinar is finished. All participants are muted, but we will show you how you can engage with us throughout today's webinar. Okay, if you want to ask questions, you can submit questions via the Q&A feature on your webinar panel. If you do not see the Q&A window, click the option on your toolbar and it will open on your screen. Type your message and submit your question here, and we will be actively monitoring this section and reading out questions to our physicians later on in today's webinar. Before typing, check to see if someone else has asked that question or a similar one. And if so, you can use the thumbs up icon to upvote a question, and this will show the panelists the most popular questions first. You can also use the chat window to ask questions we can answer about tech issues or to answer questions asked by the speakers throughout the webinar. There's a help article in the chat window if you need it as well. And if you need any more help, just message Histiocytosis Association in the chat window, or you can reach out to Heather by email at info@histio.org. So let's give it a try and just see how everything is going. Please chat us in the chat box where you're calling in from today. Hi, we have Barcelona, Colorado, Highland, Indiana, Toronto, Ontario. We have Sacramento, California, Saskatchewan, California again, Minnesota, Montana, Maryland, Tennessee, Philippines, Florida, Norway. Wow, this is amazing. Kentucky, Melbourne, Aruba, Australia, the UK, Portland, New York. Okay, so it looks like the chat function is working. Feel free to use the Q&A throughout also if you have questions, and we're so excited to be here with you today. This is fantastic. As I mentioned, the Histiocytosis Association team is honored to be here today alongside the ECD Global Alliance. We have always been very impressed by the support and resources provided for ECD patients and families. We have come together to bring information to the hands of the broader community and are looking forward to collaborating as a partnership moving forward into the future. Many new breakthroughs and treatments are coming to light, and this information has shown us that all histiocytic disorders are more closely related than we previously thought. Coming together in partnership is important so we can solve the problems across all histiocytic disorders. I want to hand this webinar now over to Diane Schreiner, the ECD Global Alliance team, and the amazing physicians who are here with us today. Diane?
Thank you, Deanna. My name is Diane Schreiner. I'm the treasurer of the ECD Global Alliance. I began working with the ECD on the board of directors in January of 2019. Kathy Brewer, the president of the ECDGA, had a last-minute family matter come up and that needed her attention today, and it may cause her to be a little late, so she asked me to step in on her behalf to do the introduction for today's webinar. I know she's doing all she can to join the meeting as quickly as possible. It is a privilege and an honor to be hosting this meeting alongside the Histiocytosis Association. Together, the HA and the ECD Global Alliance are partnering to bring this informative webinar to the community. As the scientists are learning more about ECD, they're also discovering that many of the histiocytic disorders have more in common than originally thought. With this knowledge, the HA and the ECDGA are looking for and finding ways that we can work together to help all histio patients. Through this partnership, we believe that over time, it will be possible to be more efficient, bring more services to the community, strengthen our voice, and increase research funding. We hope this webinar is just the beginning of great things that will be accomplished by working together to help the entire community. From the ECD Global Alliance, Jessie Cochran is here as the moderator today. I'm certain that the vast majority of the ECD community members know Jessie. As a director of the ECDGA, Jessie keeps everything running smoothly through her excellent organizational skills and her dedication to help all members of the community. Today, we are very pleased to bring you the major authors of the very important updated ECD consensus recommendations for evaluation, diagnosis, and treatment. The first consensus document was published in 2014 following the first ECD Global Alliance International Medical Symposium that was held in 2013. Since that time, there have been additional breakthroughs in the understanding and the treatment of ECD. This newest document, just published in May of 2020, includes updated collective understandings and the experiences of 25 leading ECD experts. Today with us is Dr. Goyal, the primary author of the consensus information to be discussed. Dr. Goyal is a hematologist and oncologist who did his fellowship with Dr. Ronald Go at Mayo Clinic in Rochester. He recently moved to the University of Alabama, Birmingham, where he has set up and leads an ECD care center. Dr. Goyal continues to become more active in the histio community, proving to be a great and upcoming leader in the field. Also with us is Dr. Diamond, a senior author of the consensus guidelines to be discussed today. Dr. Diamond is a neuro-oncologist at Memorial Sloan Kettering in New York. He's been an active leader in the ECD and histio community since 2012. He serves as the de facto medical leader of the ECD Referral Care Center Network and is the principal investigator for the ECD registry housed at Sloan Kettering. Dr. Goyal and Dr. Diamond are proving to be a very strong team for our community, as I'm sure we will all see today. They are our rock stars. And with that, I turn the mic over to them so they can share some of their vast knowledge with us.
Thank you, Diane. Hi, everyone. My name is Gaurav Goyal. I'm here with Dr. Eli Diamond to talk about updates in the ECD 2020 guidelines. We want to thank the ECD Global Alliance and Histiocytosis Association for organizing this event and for all that they do to help our patients. Over the next 25 to 30 minutes, we will go over some of the basics of ECD, including the updates that were made in the 2020 guidelines. We hope that you find it useful. We will try to cover several of the questions that we had received before the webinar during the talk, but we will also be available after the talk for a Q&A session. So what is Erdheim-Chester disease? Erdheim-Chester disease is a disorder of abnormal growth of certain blood cells. The cells are called as histiocytes, hence the name histiocytic disorders. And Erdheim-Chester is a subtype of a histiocytic disorder. And those cells tend to grow into different organ systems and tissues, causing various symptoms. One of the updates that happened since the previous guidelines was that ECD was recognized as a type of blood cancer by the World Health Organization in 2016. And this was due to the discovery of BRAF and other mutations in the tumor tissue of patients. ECD can involve one organ or multiple organ systems. It can have a wide variety of manifestations, and we will talk about it later today. The first ECD guidelines were published in 2014. This effort was led by Dr. Eli Diamond in collaboration with the ECD Global Alliance and several other physicians and scientists across the globe, as you can see listed below. The idea of updated guidelines, it emerged at the ECD Global Alliance meeting in 2017. And this was partly because we had new advances in the field, including BRAF inhibitor treatments and discovery of other mutations that was made in ECD beyond BRAF V600 mutation. The first discussion of the updates was made in 2017, and that led on to the next meeting in 2019. This led to the creation of recommendations that were then voted upon by all the authors and led to the publication of the guidelines last month. As you can see, the updated guidelines has almost twice the number of authors as compared to the previous 2014 guidelines. This highlights how many new physicians and scientists across the globe are coming together and collaborating to improve the care of ECD patients. And we are thankful to the ECD Global Alliance to provide a platform for all of us to come together and work on that cause. The question really is, why did we need the new guidelines? What happened since the last guidelines that required the need of new guidelines? There were several advances in the field that occurred since the last guidelines. The major breakthrough was the approval of a drug, vemurafenib, for ECD patients who had BRAF V600E mutation in 2017 by the US FDA. This was the first drug approval in ECD, and it came almost over 80 years after the first description of the disease in 1930. In addition, we found out about new mutations beyond BRAF V600E in the MAP kinase pathway that we will talk about later. In addition, there was a new study led by Dr. Eli Diamond and group to show the efficacy of cobimetinib in patients who do not have the BRAF V600E mutation. So that was incorporated as a treatment option as well. Finally, the National Institute of Health study on natural history of Erdheim-Chester disease was published, which gave us insights into various organ manifestations of ECD in a uniform fashion of imaging studies such as PET scan and MRIs. Therefore, new guidelines were needed to optimize the diagnosis and treatment of ECD because of the new complexities involved with this new information.
Hi, everyone. I'm Eli Diamond, and I'm really pleased to be here with the HA and the ECD Global Alliance and with Gaurav. So I echo his sentiments and his thanks. It was really a great collaboration to work on these guidelines with Gaurav and with all of our colleagues in the ECD community, and it's something that we take a lot of pride in together, and we hope that it helps the patient community and it helps other physicians take the best possible care of ECD patients. So this is a very skillful image from one of Gaurav's articles, which shows all the different parts of the body that ECD commonly affects. In reality, it's a head-to-toe disease. There isn't a part of the body that someone hasn't found ECD to be involved in. But that said, there are particular areas of the body that are more commonly involved than others. So if you look at this figure here, you see that there's there's arrows to different areas of the body and then a percentage. And that's an estimate of what percent of ECD patients have that part of their body involved. One thing that changed from the era of the previous guidelines to now is that in a lot of ways, these numbers are higher, which is to say that ECD involvement is more recognized across the body than it was. And one of the reasons for that is that historically, the ECD patient population in France was pretty much the dominant source of information that we had about the disease. And in the last few years, there's more knowledge that has come about from the NIH study. So all of you in the audience who participated in that, you contributed to that knowledge. And also from the Mayo Clinic, from what Gaurav has done, and from Memorial Sloan Kettering as well. So ECD is more recognized in different parts of the body now. there is, when I think about a patient, one of the questions that we ask ourselves is, what part of the body is involved? Where can you see ECD to be present? And that may be different from if it is affecting someone's health in that area of the body. And that furthermore may be different from whether it's causing symptoms in that part of the body. So for example, someone can have ECD around the kidneys and have no symptoms, but could have problems with their kidneys. Or you could have ECD in the bones, and it doesn't affect your bone health per se, but can cause incapacitating pain. So this is sort of some of the complexity that we have to think about when we're evaluating a new patient. So just to take a quick tour around this figure, about say a third of ECD patients have some involvement in or around the brain, and a large number have some kind of abnormality of the pituitary, which can cause different kinds of hormone problems. Different kinds of arteries in and around the heart can be affected. And the bones is pretty much one of the most common and hallmark manifestations of ECD, that there can be abnormalities in the bones of the legs. And there can be problems behind the eyes and in the skin around the eyes, also in the lungs, in about half of patients around the kidneys, and then in the testes in a small percentage of men. This is not a popular area to biopsy, as you can imagine, so this may be more common than is recognized. This is a very user-friendly diagram from the Global Alliance that's adapted from Gaurav's figure, which shows all the different kinds of symptoms that can happen as a result of ECD affecting these different areas of the body. So something that we're commonly asked about is the difference between ECD and some of its what we call its cousin diseases. So Langerhans cell histiocytosis is a much more common histiocytic disorder, but it has key differences with ECD. So one is that Langerhans affects predominantly younger people. It's probably 3 to 5 times more common in kids than it is in adults, whereas the opposite is true for ECD. It's primarily a disease of middle age with some exceptions of younger individuals. ECD is also a condition that affects predominantly men, probably about 3 times as frequently, whereas Langerhans is more evenly distributed. Langerhans affects the brain, looking at this diagram, far more uncommonly than ECD does. It does affect the bones. Bones and the skin are some of the most common locations, although oddly enough, it's different kinds of bones. Langerhans tends to affect bones that are more in the center of the body, the skull, the spine, the shoulder blade, the hips, whereas ECD is usually further out, further down in the legs or the arms. The skin problems from Langerhans are quite different. They're these sort of red, angry, very painful. Someone can be thought to have a wound that did not heal or an infection that didn't heal for quite a long time, and then it ends up being found to be Langerhans. That's not really quite the case for ECD. The hormone problems is one very similar feature between the two conditions, and interestingly, some of these hormone problems can predate someone's diagnosis by a very long time, which is to say 5, 10, 20, even more years. Lymph nodes is something that has been found in Erdheim-Chester, but is very uncommon, but is more common in Langerhans. And then there is a whole sort of independent thing that is Langerhans in the lungs. And that is sort of it's a unique disease that in many instances is brought about by smoking and can be treated by smoking cessation, by stopping smoking. So while lungs can be affected by ECD, there really isn't that kind of relationship between smoking causing it or stopping smoking helping it. Rosai-Dorfman is another disorder which can have some similarities to ECD. Like Langerhans, it's something that affects younger people more than older people, but can affect across the spectrum. It's a condition which predominantly affects the lymph nodes. Unlike Erdheim-Chester, the lymph nodes and the skin. And one of the main differences between Rosai-Dorfman and ECD is that Rosai-Dorfman is most commonly something that does not affect the body extensively, one or two locations. It does not become a very big health problem. There are rare instances in which it can kind of seem like ECD involving the brain or behind the eyes. And so it's a small number of those individuals that have a very severe form, and those kind of behave more like ECD. When it comes to these other histiocytoses, what has been appreciated in the last few years is that there's a bit of a slippage between all of them, and that patients can have more than one. They can have both ECD and Langerhans and ECD and Rosai-Dorfman. And so that has had us be more aware of examining patients for whether they could have not only one, but two of these.
One of the questions that keeps coming up when we talk about histiocytosis, especially in ECD, is what is the MAPK pathway and what is a mutation? The figure on the right basically shows the MAPK pathway, but in simple terms, MAPK pathway is a series of genes that are present in cells, and they create certain proteins. Their job is to carry a signal from the outside of the cell to the inside and tell the cell to start multiplying and promoting cell growth. What a mutation is, and we call it as a somatic mutation. This has to be differentiated from the mutation that occurs in germline, and that is the DNA that you get from your parents or you transmit to your kids. This has to be differentiated because one of the questions that keeps coming up is, is ECD hereditary? Is this something I will transmit to my kids? So when we use the word mutation, I want to make it clear here that these mutations that we talk about are in the DNA of the cancer cells or the histiocytes. And there is not a lot of evidence that we have found to date that that ECD can be transmitted to children and so forth. So what is a somatic mutation? It is a change in the DNA of the cancer cell that basically creates an abnormal protein. What it does, it tells the cell to start multiplying more rapidly. And the thought is that these mutations can lead to the growth of the tumor of ECD in various organ systems. On the pie chart to your left, you can see the various mutations that have been discovered over the last several years. The most common and the first mutation that was discovered is the BRAF V600E mutation that can be seen in half of the ECD patients. And that can be targeted by BRAF inhibitors such as vemurafenib and dabrafenib. Rest of the mutations that are shown in the pie chart have been discovered over the last 5 to 10 years as well. And what we are realizing that over 90% of ECD tumors harbor one of these mutations or these genetic changes or errors in the genes of the cancer cell, which can be mapped to K1, KRAS, NRAS, and so forth. And that can lead to the cell growth. Some of these mutations can be targeted by specific inhibitors, such as MEK inhibitors, and so forth. And they are being studied currently in clinical trials. A knowledge of the mutations in ECD is very important for choosing treatment options. And we will discuss that in the treatment algorithm section. It is to be noted again, because there was one of the questions from the audience that are there any genetic factors that lead to ECD? We are not aware of any as of now that can promote ECD development, or we can predict who will develop ECD in advance. How to diagnose ECD? One of the goals of the updated ECD guidelines was to improve the diagnosis of ECD. so that the patients don't have to wait for years to get the correct diagnosis and treatment. The new ECD guidelines acknowledge that there are several instances where classic ECD features may not be present, either clinically or under the microscope. And in those circumstances, it relies on the mutations, the presence of the mutations, to make a diagnosis of ECD. This allows some of the cases that historically would have not been called as ECD to be now diagnosed correctly as ECD and get treated appropriately. For example, you could have a case that is unusual in the sense that they do not have the classic features as seen under the microscope, but they have these clinical features of long bone involvement, the rash around the eye, or some of the other features Dr. Diamond mentioned earlier. But if they have one of these mutations, that leads to the diagnosis of ECD now. Similarly, you could have cases where you have the features under the microscope, but you don't have these bone involvement that are thought to be seen in almost all cases of ECD, but have one of these mutations. In those cases, a diagnosis of histiocytosis or ECD can be made as well.
So this is a portion of the guidelines that is meant to be a roadmap. So this is meant to be a roadmap for any clinician or physician who is evaluating a new ECD patient. And this is meant to walk them through all of the questions they're supposed to ask and the examinations they're supposed to do so that they can do a comprehensive assessment of that person. And this was derived from all of the authors on the paper thinking about it together, sharing their experiences so that this roadmap can be as accurate as possible. And so what it involves is different elements of the medical history, things that the patient should be asked, but different experiences or symptoms they have, different parts of the physical examination, and what other specialties should be involved to evaluate someone, both to see whether that part of their body is affected, but also to help guide treatment and to manage side effects. One of the big changes in the paper now from before is that there's an emphasis on the PET scan. This is something that we consider to be very, very important in the assessment of both new ECD and to evaluate whether a treatment is working. We believe strongly that this should be in this guidelines paper because we all still get denials of coverage for PET scans, and we have to point to something authoritative to be able to substantiate the need for the PET scan to be covered. We're hoping that this will accomplish that. One of the other tests that should be done is an MRI of the brain and a scan of the heart. Down below is an explanation of the different gene testing, the tests for mutations that Gaurav just mentioned to be done. This is something that also we're hoping will make more likely that these gene tests will be covered, because that's something that is also debated sometimes. This is spelled out here for any physician to be able to know what kinds of tests they should be ordering on the ECD material. So I just want to tell you guys a little bit about what we mean when we say gene testing and how you do that. So the best way to test for the ECD mutation is to test the actual biopsy material. One of the unfortunate ironies is that often people have biopsies of their bones because the bones is one of the most common sites of disease. However, one of the ways that bone biopsies are processed is this process called decalcification. And that is just sometimes what's necessary for a pathologist to look at it under the microscope. Unfortunately, decalcification does things to the genes in the sample, and it sometimes renders the material difficult or impossible for gene testing. So that's a complication that people run into. There are different kinds of ways to test the biopsy. Some institutions have what's called an in-house testing, meaning it's done within their institution. and some it's called a send out, which means that someone has to know that there's a company out there which will do this testing and they can send the material to them. A few years ago, often you would send the material just for BRAF testing and you got a yes, no on the BRAF result. Now there are these what are called multi-gene, or ideally something called next generation sequencing, which can take the biopsy material and look for gene mutations in dozens, if not hundreds of gene mutations all at once. Rarely there are gene mutations called fusions. Those are uncommon, but those are the kinds of things that we keep in mind because some of the conventional testing methods don't look for those. And you have to think about it and send them for a particular fusion type test. So if tumor material isn't available, we sometimes do what's called liquid biopsies, which is looking for mutations in the blood. There are some commercial tests for these companies that do it, and a small number of institutions have those within their walls. So what this basically is taking the blood and trying to look for teeny tiny amounts of the ECD DNA that's floating around in the blood, isolating those, and then doing the same gene testing that you would do on the tumor. So for testing for the BRAF mutation in particular, those blood tests can be very good, and there's a decent level of experience with those. Looking for mutations outside of BRAF, it's something that's coming along, but is not quite ready for prime time in terms of how reliable it is. But it can be worth doing when there's no other option. And we think that these tests to look for mutations in the blood are probably more accurate when someone is not treated, when they're in their untreated state, when there's more of that ECD DNA floating around. I do want to take a moment to make a plug for an initiative that we have at MSK, which is aimed to try and find the ECD mutation in as many histiocytosis patients as possible. And so following the webinar, that information will be sent out about how you can access that initiative if your ECD has not been sequenced in the past.
What are the treatment options for ECD? Over the several years, many drugs have been tried for ECD with variable success rates. Now, over the last 5 years or so, we are seeing high success rates with targeted therapies. The way we think of treatments for ECD is we divide them into two categories: the targeted therapies, and the rest of them we lump them together as conventional agents. Targeted therapies include the BRAF inhibitors or the MEK inhibitors. It is to be noted only vemurafenib is approved currently by the FDA, but rest of the drugs are available and have been used in melanoma and other cancers for several years. Conventional agents, the most common conventional agent that has the most experience available is interferon, and pegylated interferon is thought to be slightly well tolerated as compared to interferon alpha. There are several chemotherapy agents that have been used as well. I have experience with using cladribine, and we have published on that before, and that can be an option as well. In anti-cytokine therapy, these are called as biologics, used a lot by our rheumatology colleagues for autoimmune conditions. These are the one with the most experience is anakinra, which is given as an injection under the skin. But there are several other treatment options that have been tried as well. How do we approach treatment of ECD? When we see an ECD patient, we first evaluate whether there are any symptoms from the disease, and like Dr. Diamond mentioned earlier, we stage the disease to see what organs are involved. There are very certain, although rare situations where the patients either don't have symptoms or have maybe one organ involved, a little bit of disease in the bone or kidney as such without any problems, and we can monitor them without treatment, but with a follow-up imaging to see if it's growing or causing any problems down the road. However, most of the ECD patients actually need treatment at the time of diagnosis due to the symptoms they have from the disease. We encourage participation in a clinical trial if available nearby you at an institution, and we will send you a list of the ongoing clinical trials after the webinar. Otherwise, the treatment of ECD, as you can see, has become increasingly complex with the targeted agents coming into the field. We think of the treatments as based on what is the mutation status of the ECD. If we see the presence of a BRAF V600E mutation, we try to use a BRAF inhibitor if possible, especially if the symptoms are severe or you have brain, heart, or other critical organ involvement, because we know the treatment will have desired efficacy and will lead to shrinkage of the tumors. If the symptoms are non-severe, you could consider conventional agent or a BRAF inhibitor, although more and more data are showing up that BRAF inhibitor would be preferred in this situation as well. But it also depends on the availability of the drug and the tolerance of the drug and side effects you have on how you tolerate it. The other situation would be when you don't have a BRAF V600E mutation and you have some of the other mutations that I discussed earlier. In those cases, we can consider treatment with a MEK inhibitor, such as cobimetinib, Cotellic, and that is what the trial from Dr. Eli Diamond's group was about, or you could try a conventional agent. It is to be noted, there are certain rare gene changes in the genes called as gene fusions that we are discovering in ECD, such as ALK, RET, and TRK, which actually have specific inhibitors beyond the BRAF and MEK inhibitors that could be tried. They are not approved for ECD at this moment, or we could try a conventional agent. There are new data on some mutations called as CSF1R mutations, which have targeted treatments as well, but there hasn't been no experience in terms of any published cases with the use of that drug. Now, it is to be noted, like Dr. Diamond mentioned earlier, that there are situations where we are unable to test for the mutations, such as a bone biopsy that has been decalcified, or there are situations where the number of cells in the biopsy are very low, so we cannot get enough DNA to test for the mutations. The other situation is when the patient is very sick and we don't have time to wait for the mutation results, which sometimes can take over a week or two to come back. And in those situations, it is very reasonable to consider empiric treatment with a MEK inhibitor if the suspicion for ECD is high, or one of the conventional agents with more experience. How do you monitor ECD once treatment has started? As mentioned earlier, most of the ECD patients will get a PET scan. We recommend doing it in all ECD patients to get a sense of what organs are involved. And based on that, after you start a treatment, we recommend repeating the PET scan approximately 2 to 3 months after that to see if there is a response. With targeted therapies, you should be able to start seeing some response in a few weeks of starting the drug. But thereafter, you may have to repeat a PET scan every 3 to 6 months to see if the disease is stable. Beyond that, this can be adjusted based on your comfort, your physician's comfort, and how you are tolerating the drug. In addition, you may need a CT scan or an MRI, depending on what organs is involved. For example, if there is involvement of the brain, then you may need additional MRI to see if there is any improvement in the lesions in the tumors of ECD in the brain. The other thing to note is that the ECD can be associated with hormone imbalances in a large proportion of patients. So endocrine evaluation is very important. Even though you are getting treated for ECD, it is very important to get hormone evaluations and get those hormones replaced and keep an eye out on that, because they can affect your symptoms a lot. We are realizing more and more that even though some of the new treatments are resulting in very good responses to the ECD, there are symptoms that don't entirely go away. And in addition, there may be side effects from the treatment that may lead to some symptoms such as pain, fatigue, and so forth. So we highly recommend working with supportive care colleagues or palliative care, depending on what center you are in, for pain management and other symptoms as they occur alongside. You may need additional tests based on what treatment you are on and so forth. This also highlights how complex the management of ECD has now become. And that is why it may be reasonable to actually get evaluated at one of the centers with expertise. And there is such a list maintained by ECD Global Alliance and also by Histiocytosis Association for an opinion. I think you're muted, Eli.
Sorry, thank you. I was blocking out the traffic. The more we've used these BRAF and MEK inhibitors over these years, we've become familiar with the spectrum of side effects and how they can be, sort of mild nuisances to completely incapacitating, and in some cases can be worse, it seems, than the disease ever was itself. So this is sort of one of the biggest struggles that we have treating ECD. I want to introduce the concept of a dose-limiting side effect versus a treatment-limiting side effect. A dose-limiting side effect is something that limits the amount of medication you can take, but ideally not the fact that you can take it itself, and that giving you less of the medicine will make that side effect either go away or more tolerable. Treatment limiting means if something happens as a result that is a go, no-go type event, and that you simply cannot take the medication anymore. And we want to distinguish these to the extent possible and not consider something treatment limiting when in fact it could be made better by limiting the dose. So some of the most very common side effects are rash and other skin problems, joint pains, fatigue is invariably present, different kinds of gastrointestinal side effects, and then a range of different lab value type things, which may or may not affect your health. Rare but serious type complications are eye or heart problems, rarely second cancers, and those are things that can limit treatment entirely and not just a matter of dose. I want to make the point that handling side effects is really, it's an art. And it's a matter of trial and error and a matter of experience and trying different things. There isn't one way to do it, but it takes some experience and dedication from everyone involved to try to get someone on the best possible dose and supportive care regimen. And I think that this is one domain, managing side effects and drug dosage that is, there's no replacement for experienced ECD care for this set of issues. Something that comes up is, how long should I be treated? We don't know what's best. We think from some evidence that if people stop treatment entirely, eventually their ECD will come back. When, we don't really know, but I think that our experience is that it will likely come back in some form at some point. So what can you do about that? Some people can be maintained on very small doses of medication, it would seem, indefinitely, if it's tolerable. That can work for some people, not for others. It may be best in some instances to pause treatment altogether to see what happens, but that can't be done willy-nilly. That has to be done with a very close surveillance plan so that if the ECD reactivates, we'll know how and when. And how to think about the long-term is really a case-by-case type determination that is based on the specifics of someone's disease, what kinds of complications they have had, and what different kinds of doses they've been able to tolerate. So some parting suggestions from Gaurav and me is to learn as much about your particular case as you can. Maybe revisit what parts of your body are involved, in what ways your health is affected, learn about the gene mutations that you may have and whether that may open up any new avenues of treatment, re-examine treatments that may have been written off because of a side effect you had. I've heard many times that a medication was stopped because this happened, but in reality, there may have been another way to administer that medication and avoid that complication. I always make the point to tell people to treat depression. Depression is extremely common in this disease, probably as a result of many factors. And to say that it's a difficult illness and coping is difficult, and if you had this, wouldn't you be depressed too? That's not sufficient. I think that treating depression often with antidepressants can really help coping and help with quality of life. So that is something that I always plug. Consider a second opinion depending on your case. One of the gifts of the pandemic has been the expansion of telemedicine. So you may be able to get a second opinion from an expert that wasn't available previously. And then if you can, get involved in research, whether it's through the ECD registry, and that's something that's supported by the Global Alliance. That's all.
Thank you, guys. That was very helpful. And I believe you've covered several of the questions that we received before the meeting. We had some come through on the question and answer set on the side. You can see the number one question was, can you please address the very common ECD fatigue and what causes it?
I wish I could. In a study that I did of ECD patients, which is mainly people who are treated, 70% report fatigue. So I think it's far and away the most common symptom. I think it has many causes, inflammation in the body and the medications people take. It can be hormone abnormalities. So it's far and away the toughest thing that you guys have to, deal with, and it has many causes.
Thank you. The second question was, does dabrafenib arrest or reverse the cell growth?
Yes, so this has been a matter of discussions for a while, because we know now that from a French study that, and from our experience, that when you stop the BRAF inhibitor, there is a chance that the ECD will come back, which necessitates sort of long-term treatment with these drugs. And we don't have a lot of evidence to suggest whether dabrafenib or vemurafenib kills the histiocytes causing ECD. There was a small study done from our Italian colleagues in cell culture media that showed that these targeted agents, BRAF and MEK inhibitors, slow down the growth of the cancer cells and not necessarily kill them. So we don't know. That is why one of the areas that we are trying to investigate is how can we optimize the treatment with targeted therapy, whether this needs to be combined with some other treatment to sort of to find a way to do a limited duration of treatment and kill the histiocytes of ECD.
Thank you. Kevin asked, what are some of the known second cancers that can be caused by mechanist or the MEK inhibitors?
There are not. That's a phenomenon that is fairly unique to the BRAF inhibitors and is not known to happen with the MEK inhibitors.
Okay. We've got more questions. Can you discuss why tapering works with targeted therapy?
I guess if I understand the question, they're asking, I don't know if tapering works, but the question, the real question, I guess, is, can you taper targeted therapy in ECD patients? And the answer is yes. In our experience, and actually it's not been published yet, but it's accepted for publication. We looked at our cases where we cut down the doses to quite low doses, and there were a few patients who we were able to lower the dose just based on the side effects. But again, like Dr. Diamond said, that it has to be done by our ECD physician who is sort of monitoring you very closely. And if you are able to, if you and your physician decide that you're going to take a break from the drug after tapering it off, if you develop symptoms, or you need to be in touch with your oncologist or hematologist to see if the ECD is coming back and whether you need to start the treatment again.
Thank you. Another question is, will having targeted agents allow patients to return to baseline functions?
I mean, that's always our wish, and it always depends on what kinds of functions you're talking about. We have seen some really inspiring cases where people who start treatment in quite a disabled state, have really very dramatic recoveries. And then there are instances that are disappointing in the extent of recovery that people have. We don't know exactly what are the factors that determine it. It could be how long someone has had a particular problem and how reversible it is. But that's something that we see a range of, and we don't really quite understand why.
Okay. Going through the questions here. If you guys see one you want to answer, just grab it.
Yeah, so there is a question that was upvoted, was do any treatments reduce or remove the fibrotic tissue? So prior to doing PET scans, what we have realized about ECD is, and like it was pointed out, is the ECD releases, ECD itself doesn't, the histiocytes are not that many in a tumor, but it brings back a lot, it recruits a lot of other cells that release a lot of sort of, for a lack of a better word, junk in the organ systems. And if we were not doing PET scans, it's not uncommon to see that you treat the patients feel better, but the junk, sort of the dead cells or the fibrosis, is so we call it, it still remains behind. And that is why if you were to strictly check out how much response there is, you may not have the entire normalization of how it looks on a CT scan or an MRI. But with the PET scan, now you're able to see, yes, that there may be some fibrosis left, but it may not be active cells. It may all be dead cells or very barely growing cells.
Thank you. We've had a few more favorite questions. One is, what is the average time in which a delay in reaching the diagnosis of ECD can compromise the treatment? From what moment can you expect a bad prognosis?
I think that's really tough to answer because I would say we often really have no idea how long someone may have had ECD. Someone may be diagnosed and then you revisit a health problem they had, much earlier in life, and in retrospect, we realized that it was the result of ECD. So that's a question that's very, very that's very hard to answer.
Thank you. So we have, is ECD actually a blood cancer?
Yes, and in my first slide, it was mentioned, one of the major changes that happened from the 2014 guidelines to now is in 2016, the World Health Organization officially recognized ECD as a blood cancer. They have their own category called as histiocytic neoplasms. So it is grouped along with Langerhans cell histiocytosis. Now, when patients hear the word cancer or a blood cancer, sometimes they are used to, or they know other people around them who suffered from more common yet more aggressive cancers such as leukemias or lymphomas. I just want to make a plug there that yes, it is a blood cancer, but would not equate it to leukemias or others. It is a slow growing blood cancer if you want to categorize it at one type of cancer or not.
If you cannot receive care at an ECD care center, what type of doctor would you recommend?
This is something that has changed over the years. when ECD was thought to be an autoimmune, like a problem with the immune system, it was managed mostly by rheumatologists. I think that now the treatments are more in the arsenal of oncologists, and usually blood oncologists or medical oncologists. If you had to pick one specialty, who's most likely to have a familiarity with the treatments.
There was a mention of unpublished findings. What are the other emerging things happening with ECD?
Yeah, so in ECD actually, and other histiocytosis, you know, the things that are emerging are, as I had briefly mentioned, you know, recently we found out about newer mutations. As we sequence, as we do genetic testing on more and more patients, we are actually uncovering new and new mutations, and we are trying to find ways to harness those mutations to treat patients appropriately. The other things that Eli's group has been looking at, and he can talk more about it, is, you know, how do patients, patients who are surviving with ECD or who are on treatments, you know, what symptoms do they have, and how we can sort of make sure that that symptom burden is reduced. At the same time, one of my own interest is to look at combination treatments in such a way that we can ultimately we can cure ECD for that matter in a systematic way, to actually study some of the old drugs and combining with the new drugs and so forth. It's not ready for prime time by any means, but there are numerous studies that are undergoing, and through our collaborations with Eli and several other folks across the globe.
If treatment is put someone into remission, as their doctor may call it, will it change the BRAF status?
No. So that mutation is what we think will always be the mutation that drives the disease. And in almost all cases, what we've learned is that it seems like one's ECD is kind of addicted to the one mutation that it has, and that's the defining mutation over time. So we think that the activity of the mutation is suppressed with the treatment, but it always remains what would drive it.
Thank you. I want to open up the Q&A to the speakers if you have any more questions you would like to answer live. Otherwise, I think we can put together a Q&A for the attendees following the video, just for the interest of time.
Yeah, if I can just go over a couple of these questions, and Eli, you can see if you like any of those, anything that we missed. So main concerns with low dose long-term use of targeted therapy, like was mentioned before, one thing that we are realizing is, and we have learned it from melanoma and other cancers, is if you are on BRAF inhibitor for a long time, there is this theoretical risk, or there is a risk that you may develop skin cancers and other cancers down the road. Of course, there are heart and eye concerns as well. So we have to watch out for those. So it's very important to monitor for those things as you develop new symptoms. That's about it, about that question. There were a couple of questions about.
The only thing I would add to that is that the low doses of the medications don't probably get into the brain very well. So people on low doses can have sort of a mildly compromised neurologic state over time, because if they have ECD in the brain, it remains partially treated.
The other question that I saw in the previous, in the questions as well, is, does ECD cause blood clots? Any cancer, for that matter, blood cancer, can lead to blood clots. We know that, ECD by itself, we have seen blood clots with ECD. It can involve the blood vessels and lead to occlusions, and, even blood vessels around the heart sometimes. So certainly it can be associated with blood clots. I don't know what, Eli, your experience has been.
Fairly uncommon, I would say, without another provoking factor.
Yeah, it's variable, I guess. So, as you can see between us two, we have, I have seen some blood clots, but it may be uncommon for sure if you do a large study. Okay, I think there are other questions, but we are out of, we are at 4 p.m. already.
Yes, we will definitely try to get all of these questions answered as best we can and send it in a Q&A file along with the recording, the slides, and we will also let you know about trials that are open for ECD patients. And so if anyone has any other questions, you can still submit them to any of our email addresses that you see for our contact information. We will also have a post-webinar survey that we would love for you to fill out for us to help us improve our process and give us ideas for more webinars throughout the year. So we will definitely try to address any concerns you have. If we see a common interest in webinars, we will try to get speakers together and get those out to you guys. We just want to thank the host for taking time and the speakers for taking time today to share their expertise and go over this document. It's a very interesting document, but it's difficult to read for us laymen. So we thank you for helping us out today and answering all of our questions. And thank you for the attendees for your participation, for joining us today. Like I said, we will email you following the webinar as soon as possible with a recording and all the links that we think you will find helpful. If you've opted to share your information with the other attendees, we will also send you a list of names and emails. And also just keep watching your inbox for more information. We will try to have more support available like this in the future through webinars this year. So thank you very much for joining us, and we can't wait to see you again.